Primary intestinal lymphangiectasia is a rare congenital disorder of lymphatic system. This is characterized by abnormally dilated lymphatic and excessive enteric loss of lymph fluid rich in plasma protein, chylomicron, and lymphocytes. So far, suggested mechanisms of lymphatic fluid loss are exudation from the epithelium and rupture of dilated lymphatics due to blocked flow. The disorder can be partially controlled with dietary modification, surgical resection if localized, lymphatic decompression, administration of octreotide, and recently antiplasmin therapy. A 17-year-old female presented with progressive edema of both lower legs over several years. She also complained of frequent loose stools, generalized weakness, and lower leg edema beginning since childhood. There was no steatorrhea or body weight loss. Both past medical history and family history were unremarkable. The patient had puffy face, mild pitting edema in abdominal wall, and severe pitting edema in both lower legs. Laboratory findings showed lymphocytopenia, hypoproteinemia, and hypoalbuminemia. Total cholesterol and triglycerides showed decreases. However, renal and liver function tests were within normal. There was no urinary loss of albumin. Stool exam had ruled out steatorrhea. Plasma clearance of alpha-1 antitrypsin showed an increase to 760 milliliters per day. Technetium-99m labeled human serum albumin scan revealed leak of radioisotopes from ascending and transverse colons beginning 6 hours after injection. Initial gastroduodenoscopic findings consisted of numerous tiny white spots scattered all over from duodenal bulb portion to third portion. Distal part of the third portion was not involved. This is lower power view of duodenal biopsy showing dilated lymphatics in lamina propria. CT scan of the abdomen in this patient showed concentric wall thickening in the duodenal third portion, small amount of ascites in pelvic cavity, and no retroperitoneal mass or enlarged lymph nodes. Then, how can the following be explained? First, limited clinical improvement after lymphatics decompression by lymphovenous anastomosis. Second, dilated lymphatic vessels found only in the tip of villi. Third, scattered white spots in the mucosa, not in the subepithelial layer as typical endoscopic finding. After a day of high-fat meal, repeat gastroduodenoscopy was done. In the interim, reflux of milky fluid from duodenum is seen. Also, pool of milky fluid is noted in the bulb portion. Numerous white spots have become more prominent and increased in numbers. Argon plasma coagulation set at 40 watts was applied to coagulate the involved duodenal mucosa. Pinpoint coagulation technique was used. APC was not applied on the major duodenal papilla. 3 sessions of APC, each 2 months apart, were done without significant complications. 6 months after 3 sessions of APC, follow-up endoscopy showed disappeared oozing, marked decrease in number of white spots. Although fugulation was not done on major duodenal papilla or duodenal third portion, no new region appeared. Endoscopic ultrasound also demonstrated no abnormally dilated structures. Lower power view of follow-up and duodenal biopsy demonstrated disappearance of dilated lymphatics in lamina propria. Technetium-99m labeled human serum albumin lymphoscintigraphy demonstrated no enteric loss or abnormally dilated lymphatics. At 6 months after therapy with APC, serum protein, albumin, and blood lymphocyte count have normalized and remain normal afterwards. Also, alpha-1 antitrypsin clearance rate has decreased to 29 milliliters per day. In conclusion, lymphatic fluid seems to ooze from ruptured lymphatics in this patient. This finding may be attributed to abnormally fragile lymphatics susceptible even to a physiologic increase in lymphatic pressure. Endoscopic ablation therapy using argon plasma coagulation seems safe and efficacious in treating protein-losing enteropathy and lymphocytopenia associated with primary intestinal lymphangiectasia. Its effect is also durable.